So, hi, I'm Rob Stowe. I'm from Boston Children's, and I get to kind of wrap up this presentation. I'll be talking about sleep disorders in individuals with developmental and epileptic encephalopathies, and trying to ask that question about, is better sleep an outcome, or is it a mechanism to improve our other endpoints? Let's see. It works. I don't have any relevant disclosures. And in terms of my general objectives, in the short 15-minute time frame, I'm going to try and describe the association of sleep disorders in children and adults with DEEs, discuss some of the challenges in quantifying, qualifying, and defining better sleep. And I think a lot of my colleagues here have already started to address that elephant of it's hard. And then, try to discuss some of the potential impacts of what quote unquote better sleep means. How does that influence things like seizures, behavior, and development? And of course, this is just how I feel with most of my talks. All right, so I think I'm not going to try to belabor too much of this because I think a lot of folks have talked about it, but when we talk about sleep disorders, it is not, when you ask, my child's sleep is not good, it is not sufficient, it is not where I want it to be, where that takes sometimes more than one clinic visit to really understand what are you trying to tell me. And so when you're an epilepsy physician and a sleep physician like myself, I don't necessarily have all the time in the world to address how are your seizures, how is your sleep. So it can take a while to really disentangle this. We can talk about abnormal patterns, the amount of sleep. My child gets too much, too little. Usually it's probably more too little. It can be the insomnia, and whether this is the difficulty in initiation of sleep, difficulty in maintenance of sleep. It is the potential behavioral components of insomnia as well, whether it's inappropriate sleep associations. There can be hypersomnia, the excessive sleepiness and sleepiness at inappropriate times in the day. We can talk about architectural changes to sleep from a macro scale, like the appropriate amounts of non-REM, stage 1, 2, 3, the appropriate amount of rapid eye movement, REM sleep. We can get into the microarchitecture changes of things like cyclic alternating patterns, spindle densities, and things of that nature. And then we can also go through circadian rhythm disorders, individuals who may have delayed sleep phases, advanced sleep phases, irregular sleep-wake disorders, particularly for some of our children who may be non-sighted. And, we can measure sleep in a lot of various ways. The upper right-hand corner kind of shows a quantitative EEG showing like, oh, look at this nice progression of sleep over I think it's about 6 hours. And I won't really belabor the process S and C that that we just received, but the idea that we've got multiple drivers of when do we go to sleep. Generally speaking, you've been awake longer, it's harder to fall asleep, or it's harder to stay awake. That's our sleep drive, that's our sleep pressure. And then we've got our inherent circadian rhythm, and there's lots of things that might influence that. The primary Zeitgeber time giver is light, but there's lots of other things that are involved there too. We could talk about abnormal breathing. So that can be the snoring, mouth breathing, neck hyperextended, dump truck sounding child, and you're thinking, okay, that's obstructive sleep apnea. Maybe you're just a loud breather and there is no diagnosable sleep apnea, but there's evidence that even children who have just primary snoring, no diagnosable obstructive sleep apnea, may have behavioral differences and learning challenges compared to children who don't snore. You can have central sleep apnea, where you actually have a loss of respiratory effort, and that's kind of what that middle PSG shows, where we really see the diminution in flow and reduction in effort in our respiratory belts. you can have hypoxemia and hypoventilation, and can conceptualize how our children, how our individuals with developmental and epileptic encephalopathies might be at higher risk for some of these things because of restrictive lung disease and hypotonia, reduced mobility. We can also start thinking about excessive movements, excessive periodic limb movements, restless leg syndrome. The challenges of restless leg syndrome is that it's a clinical diagnosis. People have talked about, trying to make these diagnoses in young children and having them draw out their symptoms because they may not necessarily have the words for it. But how do we really approach that diagnosis in someone who is nonverbal? How do they convey, I've got an uncomfortable sensation in my legs, typically legs, that gets a little bit better when I move around, and it worsens when I'm trying to go to sleep or when I'm at rest. And so I think most families should say, my kid just moves around a bunch. Like, is that restless leg syndrome? And do they have an iron deficiency? Going through that whole process. In the past few years, there's been a new diagnosis of restless sleep disorder involving just larger amplitude body movements. You can think about rhythmic movement disorders. I didn't throw this in here, but the association of parasomnias, both from arising out of non-REM and REM sleep, as also things that might disturb the typical pattern. I'm going to try and approach the next little step within the perspective of just giving us background information. So, just general evidence of sleep disorders in epilepsy. It's pretty robust. In a meta-analysis of 900 children with epilepsy, in a comparison to more than 1,400 controls, children with epilepsy tended to have reduced total sleep time, more sleep difficulties, particularly in the domains of night wakings, more parasomnias, and more sleep disorder breathing. In a study of more than 200 adult patients with epilepsy, and again, I'll mention this is just all comers of epilepsy, not specific to developmental and epileptic encephalopathies, that a strong proportion actually had a really significant amount of clinically significant insomnia. And those individuals who had insomnia had poorer seizure control, and those higher insomnia scores were contributed to poorer quality of life. And there's a great meta-analysis by Lin et al. From 2017 that really took a look at the literature evidence for incidence of obstructive sleep apnea in patients with epilepsy. And we know that with all comers and all the data that we have, maybe up to a third of patients with epilepsy may have diagnosable sleep apnea, specifically obstructive sleep apnea. And the skew was that maybe about a quarter of children with epilepsy have sleep apnea, adults a little bit higher. The actual incidence of severe sleep apnea was not so high, only 4%, but they also, when looking at these historical controls, saw that just epilepsy itself seemed to be a risk factor for sleep apnea. And interesting, in this study, perhaps not powered for this with the limited numbers achieved from all the composition, but they really didn't see refractoriness of epilepsy or the different seizure types or the number of anti-seizure medications as being risk factors for their sleep apnea, which is, I think, conceptually is challenging, and a lot of us would argue, well, we think maybe more medications make you sleepier, maybe associated with poorer muscle tone, that there would be more of an incidence of more sleep apnea with those kids who need to be on 3, 4, or more medications. When we actually try to get into the weeds of sleep disorders in developmental and epileptic encephalopathies, our information is not really it's not great. Like I can use particular examples, and I think this was a great example of a parent-driven group from sleep and Dravet syndrome. Really, the parents identified that we've been asked to do all these various sleep surveys, and they really can't communicate the breadth of abnormalities that our children experience. And I think this is something that it echoed from a lot of our conversations yesterday, that the surveys we use are not necessarily designed for the patients we're trying to study. But importantly, I think some of the key features from this study in Dravet syndrome, primarily in children with the median age of 7.5, although broad age range, including several adults, and almost a quarter of the patient respondents had individuals older than 16 years old. But I think the key things were that these are families who are highly monitoring their children's sleep because it's a big concern. Co-sleeping was a very common intervention that a lot of parents engaged in. More than half reported sleep disruptions because of seizures, but more than 3/4 actually reported non-seizure related nocturnal awakenings. Like, my kid just wakes up. And some of these children would wake up more than 30 have more than 30 awakenings per night, more than 3 times a week. So one, if they know this, that means those parents aren't getting any sleep, and it's a whole snowball rolling down the hill. We talk about some other evidence of sleep disorders and developmental and epileptic encephalopathies. These are less specific to a particular diagnosis, but there was a video PSG study of 31 children with intractable epileptic encephalopathies, and comparing these children to controls, they had decreased total sleep time, increased non-REM stage 1 sleep, which is usually a factor of saying you're having lots of arousals, and just how the American Academy of Sleep Medicine scoring rules work. If you have an arousal and you don't enter into a clear defined return to stage 2 or 3 sleep, that, hey, you're going into stage 1 sleep. Generally had lower total REM sleep compared to control groups. Several of these children had seizures during their studies, but notably this study said their apnea-hypopnea index didn't significantly differ from controls, but perhaps that their lowest number of oxygen saturation during the night was lower. What does that really mean? What is that significance? In a study of 13 adult patients with developmental and epileptic encephalopathies, in this, I think there were 6 that had LGS, and then a smattering of other diagnoses in there. Median age of 31, so these are still young adults, but sleep architecture was particularly fragmented by interictal epileptiform discharges and seizures, very high arousal index in these patients. This study showed that there had moderate to severe obstructive sleep apnea in the majority of patients, and this particular group had looked at just general epilepsy patients, and that incidence was higher in this particular group. Of course, the patients who had severe OSA had elevated BMIs as well. And they just also noted that of the patient, 6 of these patients had seizures during the study. 3 of them had tonic seizures with central apnea, and that, for some of us, that might be a concern that is a risk for SUDEP. When we try to talk about what are the origins of sleep disorders in developmental and epileptic encephalopathies, it's hard. It's a little bit of a swamp of who's pointing the finger at whom. Is it the seizures causing the sleep disorders? Is it the sleep disorders causing the seizures? Is it our anti-seizure therapies, various medications, the benzodiazepines that are causing lower muscle tone or causing excessive sleepiness? Is it our vagus nerve stimulator, which has been described in lots of ways to be associated with obstructive sleep apnea, but some perhaps more complex sleep breathing disorders? Medications for other issues, ADHD or stimulants, trying to keep these kids awake, but maybe they actually don't respond as typically as we'd like. Differences in muscle tone, hypotonia or spasticity, these types of things, limited mobility, difficulty in controlling their secretions. Their underlying genetic etiology. I think it was really important to describe that even when yesterday's conversation about, trying not to be so much of a splitter and thinking about just what is our specific etiology and trying to think, well, let's approach this more broadly, we still have to acknowledge that there are specific conditions that may have a very unique sleep physiology, like Smith-Magenis syndrome, when you have an inverted circadian rhythm. So those things might be important. Behavioral and psychiatric origins, and the other elephant in the room of extra monitoring, parental co-sleeping, pulse oximetry, SAMI cams, baby monitors, cameras, nursing, all these additional things that point us in the direction of that we're looking at these kids more. And there's at least a study from an autism, a comparison of siblings with and without autism, and parents rated the autistic siblings' sleep as poor, although from an actigraphy data, that these children actually slept the same amount as their siblings. So it was the question of, like, why did these parents so focus on this child's poor sleep when ostensibly they were sleeping the same amount as their siblings? So there is that question about how much monitoring is giving us that bias. And I know that I've run out of time, but I can tell you that treating sleep apnea can improve seizures. So if you do have a diagnosable sleep apnea, this is in adults, using CPAP actually led to a 30 times greater likelihood of reducing seizure freedom, or reducing seizure burden. And a smaller study of 9 patients pre-CPAP and post-CPAP, they actually had a reduction in their spikes in sleep. And that might further suggest that, if you have more stability in sleep, you have less cortical excitability, thus less seizures. And this, I can skip that part. I think importantly, we've already talked a little bit about the CHAT trial, the pediatric childhood adenotonsillectomy trial. But in typical children, one of the outcomes was, does this improve hyperactivity and disruptive behaviors? And the Conners rating scale, which is kind of a measure of hyperactivity and disruptive behaviors, and kind of an ADHD scale, after their sleep apnea was treated, their behaviors improved. And these were, of course, in typical children. So, and we've got some other features from adults that after epilepsy surgery, adults who had good seizure outcomes from the surgery actually had improvements in their Pittsburgh Sleep Quality Index, a giant battery of tests that look at sleep latency, sleep disturbances, sleep efficiency. All of those metrics improved. Of course, the question is this all because their seizures improved? Is it because their medications were reduced? What are there's a lot in there. We've got, just to wrap up here, I think there's very clear that there's multiple facets for us to consider when we just talk about sleep. Our best evidence supports that there's probably an increased degree of sleep disorders in individuals with epilepsy, and it probably exists to a similar extent in those with developmental and epileptic encephalopathies, although the actual data that we have to support those conclusions it's wishy-washy at this point. And we probably need to be more rigorous. And I think treatment of various sleep disorders can absolutely improve seizure control and other metrics like behavior, and perhaps treatment of epilepsy can then also improve sleep in individuals with epilepsy. And we're still at this point of trying to decide which metric should we choose to chase. Is it the treatment or is it the outcome? And I think that is my time.